Welcome to the Alain Elkann interviews, an unprecedented window into the minds of some of the most well-known and respected figures of the last 25 years.
Today we're interviewing Dr. Virgilio Sacchini of the Memorial Hospital in New York. Dr. Sacchini, in the fight for the cancer, which is your main occupation, your main interest, and you operate many people since many years, there are now new inventions, new things which seem to alleviate, to be very useful for fighting the cancer itself, but also to alleviate the secondary effects of the chemotherapy, right? And there is a new, I don't know if we can call it invention, which is made by the Avacta. And I would like to know how much this affects your work and how much this has changed the way of curing cancer.
The way to cure cancer and perhaps all the disease is benefit now from the so-called biomedical engineering. It means that the mechanical, physical, genetics, and pharmacologic engineering is helping the researcher to better diagnose, better treat cancer, all the diseases. Of course, there are many implications in the biochemical engineering. There are mechanical engineering now that is applied for robotic systems, robotic surgeries that we are doing now more and more with the better exposition of the surgical field, more precision, image in engineering, developing special medical image technologies using MRI, PET scans, CT scans altogether to better diagnose, to better localize alterations.
Is this a major step in your job and in curing cancer?
It is a major step because it's a sort of application of the best technology in treating the diseases, in treating cancers. Of course, sometimes these technologies will need to be proved with the initial clinical trials. Most of the time, these clinical trials are positive, showing a benefit in better treatment, more curability, better quality of life. So the biomedical engineering is now something that you need to consider when you treat a patient, when you do your research. And there are schools now, a medical school incorporating the biomedical engineering. So it's very, very important. But the pharmacology bioengineering is now, I would say, the most diffuse and the most useful for treating cancer.
But is it true that one of the most important benefits of this, I think it's called Avacta, no?
So this is very important. The Avacta is an incredible application of the biomedical engineering. So when we would like to most benefit of a treatment, we need two characteristics. One, to have a very powerful medication, and the other one, to be sure that the medication target the right cells. So if you have a medication very powerful, going everywhere in the body, of course, can treat the cancer, can go to the cancer cells, but may go to other cells and, of course, creating toxicity. The new concept is to target the cancer cells.
to limit the side effects
Side effects.
of
So
the chemotherapy, right?
you're perfectly right.
You go straight to the point, right? And
It goes straight to the cancer cells or the environment of the cancer cells. So this new technology of ACTA, as other technologies, but this is a very interesting technology, combine a medication that is a very well-known medication. The doxorubicin, a very powerful chemotherapy, target with a special molecule able to concentrate in the cancer environment. It means that the cancer cells may create a specific environment. It means that the cancer cells are attached together, but between the cancer cells, there is tissue. There is a sort of media, tissue with proteins, with nutrients, with capillaries. And this environment may be different if instead of a normal cell, there is a cancer cells. And so finding this difference and targeting the medication based on this difference would mean target the tissue, target the cancer to be treated and not the other organs. For instance, in this specific situation, in the ABACTA situation, they discover that in this environment between the cancer cells, there is a special protein that is called a fibroblast activation protein, and with a special monoclonal antibody. What does it mean? A special protein, they can target these cells, this fibroblastic activation protein. So what's happening that if you put together the very strong chemotherapy like the doxorubicin together with the protein attaching to this exclusive protein that we have close to the cancer cells, you can have a very high concentration of a medication of a doxorubicin into the cancer environment and kill more cancer cells and spare the other organs. Why? Because the other organs, they don't have high concentration of fibroblast activation protein, and for this reason, they are preserved from the toxicity of the doxorubicin, of the chemotherapy.
Doctor, for how long you have experienced this new technique or medicine?
Technology.
And what are the changes in your way of operating, and what are the results of it? I mean, what is the difference after having experienced this? Because now you experience this in your hospital, right?
Yes, we are experiencing different type of target treatment. One of the most, I would say, tested target treatment in cancer, breast cancer, gastric cancer, is the HR2 target medications. In some cells, there is a gene, a sequence of amino acid, a gene producing this protein, a lot of this protein, the so-called HR2 protein. And they were able to develop the target. They were able to develop the protein, the monoclonal antibody, able to kill this protein. And once you kill this protein, the cells would die. And this treatment can improve the curability of breast cancer by 40%, for instance, gastric cancer more than 40%. It means that this specific protein that you have in your cells can be targeted by a specific medication that goes over there and is able to kill the cell.
Is it also shorter? I mean, the
treatment.
For how long normally is a treatment as it was before, and how long it is now with this new method?
More or less is the same in terms of how the treatment lasts, but is the side effects and the intensity that is less. What does it mean? That you can give less drug because the drug would concentrate more in the target tissue. And a couple of years ago, there was this incredible data trial showing a very, very good improvement of the survival if you conjugate a chemotherapy to the monoclonal antibody able to target the HR2 receptors, the special receptor in breast cancer, so you have something a little more. It's like to have a rocket with a nuclear bomb inside, and the rocket is directed right away to the cancer cells, not to the body because it would destroy the body, but to the cancer cell and able to spare the other part of the body. Avacta, of course, is an incredible technology. Why? Because the drug that they are using, doxorubicin, is an incredible drug. It was one of the first chemotherapy. The limitation of this medication was the heart toxicity. So you have a limitation in giving the doxorubicin for the heart toxicity, increasing the risk of heart problems, heart attacks. But now, of course, you can improve the dose. Why? Because the drug will concentrate only in the tumor environment. And this is very, very important.
And after this treatment, how many people are, I mean, you can say that people are definitely cured. What is the percentage of relapse? I mean, that the cancer goes away or it comes back again?
So the problem is that the cancer is always a sort of mixture of cells. So you don't have the same cells in all the cancer. What does it mean? That some cancers may have the target antigens and some other cancer cells may not have the target antigens. So what does it mean? That your nuclear bomb will go only to the cells with the special markers, special antigens, but not in the other cells. And some cells may be resistant to this medication. And for this reason, they may survive, and later on, the cancer may reappear. With this technology, we target with the special Avacta technology, we target more the environment rather than the cancer cells. What does it mean? That even if you have different cancer cells, what the target, the medication does is to go into the environment and to kill all the cells independently on the type of antigen that they have. So this is something interesting because it may target all the tissue instead of selected cells. We need to understand that doxorubicin is nothing new. Doxorubicin was an old medication also called adriamycin that was discovered in Italy many, many years ago in the 80s, probably more, by the famous pharmaceutical industry called Farmitalia that then was bought by Bristol and Mayer. And so it's not something completely new. The name adriamycin means from the Adriatic, because first they discovered this medication in the Adriatic Sea, in the wild, in the algae of the Adriatic. So it's nothing new, but is the engineering that is new. What does it mean? Is the fact that they were able to combine this powerful medication to a monoclonal antibody able to target the cancer environment and make this medication more powerful in the environment.
This medication, these new techniques, you are an oncologist, but you are also a surgeon, obviously. And do you have less operations since that? I mean, you have to operate less people, or?
This is a very, very, very good question. What does it mean? That more powerful is the systemic treatment, the treatment going into the target cells, and better is for the surgeon. Why? If you do the surgery, you are not 100% sure that you eradicate all the cancer, because some cancer cells may be in the body. So if you give a very powerful medication, after you have more curability. Second important thing, you can do these medications before the surgery. So if you do this medication before the surgery, and these medications or this combination of medications work very, very well, the cancer can be destroyed, or you can have smaller cancer. What does it mean? That you can do a better surgery, a better operation. But you're perfectly right. Now there are studies in progress in which when you do your medications before the surgery, sometimes you can have the complete resolution of the cancer. So you do an MRI, a test before you see your cancer, you complete your treatment, and then you do another test and you see that the cancer is not there anymore. Of course, you cannot be 100% sure because you may have some cells there. So you do a biopsy and cells are not there anymore, and you don't do anything, just surveillance. This is a new concept, no surgery after a medical treatment and surveillance.
Doctor, how do you decide this? I mean, when a patient comes to you and you detect through the MRI, you detect that there is a cancer. What is the difference between before? I mean, there is a difference or there is no difference?
The concept now is the so-called precision medicine in you can predict. So you see the cancer, you do biopsy, you study the genome, you study the biology of this cancer, and you may say, well, this cancer is very, very sensitive to this medication, very sensitive. And you start your treatment because you know that the treatment can work very well. And then you repeat after 4 months the MRI, and you can see that your cancer is completely gone, destroyed. Of course, in your biopsy, you may see that the cancer may not respond to a treatment, and you decide to do surgery up front and not the chemotherapy, the treatment before. So we can predict better and better with the so-called precision medicine, knowing better the biology of the cancer, the response to the treatment.
The detection of cancer nowadays, sometimes it's too late, sometimes it's too big. Is there a prevention, or how do you operate yourself with your patients? You operate yourself, Dr. Sacchini, and you make all the decisions and you operate and so on, or you're part, even if you are yourself a surgeon, important doctor, you decided with other colleagues, or it's a group?
Of course, we are a strong group, medical oncologists, radiation oncologists, pathologists, genetists, genomists studying the genome. Is a strong group, and the group would give information how to treat the patient, and of course the decision is made together. Of course, with the precision medicine, what you need is information. Once you have information, you can decide yourself. So if I have the information from the pathologist that the cancer is incredibly sensitive to a specific medication, and I know I can take myself the decision. Why? Because the decision is part of a protocol, is part of something that we discuss together, and this is the pathway of the treatment. So it's not so necessary that everyone will see the patients. In some special situation, yes, but usually is personalization, and what you need is to interpret this specific information to decide the next step for the treatment.
And now this Avacta or other treatments, are they used everywhere in the world? You can be treated like this everywhere, or it's only in some specific centers that you can do that? And the other question is, patients, how do they behave? You say you have to do this and they do it, or there is a lot of thinking before doing it?
Of course, the most important thing is to have a very good relation with the patient and explain to the patient. Spend time with the patient, speak with the patient yourself, and explain the science based on your decision, because there is always a science. When you explain in detail, is extremely rare to see a patient that would escape or say, no, I don't trust, or no. The most important thing is to explain, to be very clear and explain risk, benefits, pro, contra, possible complications. In this study experiment, let's say, of this new technology, there are different phases. There is a phase 1 in which you first test the toxicity, because you will need to be sure that the drug is not toxic. So there is an animal model and there is a human model that you apply. Then you have a phase 2 in which you start to treat the patients and see the results. And then there is a phase 3. Phase 3 means you compare the standard treatment with the new technology. And then the different agency, once the phase 3 study is completed, can approve the drug, and the drug is available everywhere. In some institutions, the drug is available only in the protocol when it's still in experimental phase. But the centers are more and more in which
you can be cured with these new treatments in the United States, in Europe, in other parts of the world.
Well, of course, once we prove that the combination, the medication, the Avacta technique works, of course, is approved and you can be cured everywhere in the world. Of course, there are clinical trials that are done only at the beginning in some countries, but our clinical trials mean that you don't know the results. So clinical trials mean that the results may be positive or may be negative. Sometimes you don't have choice because there is any other treatment available, and the clinical trial may be an opportunity that you may have to have better results. At the beginning, some clinical trials are only available in some places.
As the cancer normally, I mean, you know it, of course, very well, doesn't necessarily give symptoms, right? I mean, some cancers don't give you the symptoms.
You're perfectly right.
So what do you advise to do? In the word cancer, in your specialty, I imagine that the very word creates a lot of fear, no? Paura. You know, people, the first thing they say, is it a cancer? And if you say no, but you have something else, they are relieved.
Yes.
You know? So how do you deal with it?
We have the general guidelines for the screening. First, we have the prevention, not smoking and eating well. But second, we have the early detection. Early detection means that early is the cancer, better the outcome. And there are guidelines, the mammography, the colonoscopy, the examination of your skin, these normal guidelines. But of course, we would like to have more. We would like to be able to detect the cancer before the cancer would have clinical symptoms. And now we are focusing on new technologies, new engineering technology that is, especially now, is becoming popular, the so-called ctDNA. So at a certain point in the blood, at a certain point when the cancer starts, even few cells, some cells may deteriorate and may put in your blood some DNA. The DNA of the cancer cells is different than the normal cells that we have, and there are now very powerful technologies able to detect DNA in your blood that is different than the different DNA. And you can see this DNA, check this DNA, understand if this DNA is from the breast, from the prostate, from the lung, from the pancreas, and say, look, there is something that is starting. And of course, you can investigate, you can do the MRI. Sometimes this detection is very, very early and too early to see some modifications at the normal X-ray. And you may wait, or the concept is, well, look, this new cancer, this new cell has a DNA that is different, and this DNA has a specific gene that we may target with the medication. So the future will be, well, I see this spatial different DNA. This spatial different DNA has a spatial target gene, and we can give to the patient the target medication against this gene and destroy the cancer before the cancer would be visible at any conventional thing. This will be the next future. Of course, we need to have a very high specificity. It is what they are doing, because they are doing, let's say, in a pregnant woman, before we were detecting the DNA of the fetus in the chorial veils, in the amniotic fluid. These procedures had some, of course, side effects, 3% of possible spontaneous abortion. But now you can detect the DNA fetus into the blood stream of the mom, and you can check this DNA for possible alteration of the DNA, possible diseases into the fetus. And it's done. And the concept is the same. Concept is to try to find a different DNA in your bloodstream that is the DNA of a possible cancer.
Avacta, they say this sentence, hope without compromission, right? Now, I like the word hope, but you dedicated the largest part of your life to fight, to try to stop cancers, right? Or to operate, to alleviate, whatever. After so many years, you have the feeling that it will be able to eliminate the fear of cancer one day, and that it will be just treated simply like another major illness, or it's still something so terrifying in a way, right? I mean,
for some cancers, it's always done. Some cancers can be completely treated without any problem. Prostate cancer, breast cancer. So you do the surgery, you do some medications. Sometimes you don't do anything because the cancer is very inactive. So for some cancers, yes. For other cancers, we are still working. Pancreatic cancer, some lung cancers, of course. But there was an incredible improvement of the survival, incredible improvement.
Well, in what percentage?
I would say 35% of improvement of survival without any problems, early diagnosis, better medications, The most important thing is that there is a better survival and less compromission of the quality of life. Because to cure someone and give him, her, a miserable life is terrible. So the target in this moment is better survival and quality of life, better life, less side effects. So this is the most important thing in the cancer treatment now. Of course, sometimes we can do, sometimes we may not be able in some terrible situations, but this is the target for now and the future.
But you cure better the cancer, have 35% improvement since you started. There are new techniques and all what you just said. But the cancer is an illness that has increased over the years or decreased. There are many more people who have different kind of cancers or less.
Of course, it depends. If you are able to decrease the risk, stopping smoking, increasing a lot the advertisement for not smoking, like in Brazil. In Brazil, it was incredible because they had an incredible campaign against smoking, and they were able to decrease the risk of dying for lung cancer. Of course, the most important thing is to create a sort of more information regarding the risk and try to avoid the risk, and you can succeed and have less cancer. Some other cancer, no, because you don't know. Pancreatic cancer, we don't know. It is increasing. We really don't know.
Why is cancer increasing? And another question that comes to my mind, you think that one day there may be a kind of vaccine against the cancer, as there are vaccines against many other illnesses? I mean, we cured the polio, we overcame the COVID. I mean, there are vaccines for many, many things nowadays. You think that one day there might be a vaccine against the cancer?
We have vaccines. So we have the vaccine against the papilloma virus, and the papilloma virus is the cause of cervical cancer in women or throat cancers in women and men. And people, young girls and young boys, vaccinated against the papilloma virus, and we have the vaccination at an incredible decrease in this type of cancers. So we succeed. Unfortunately, we don't know all the causes of cancers, and often the cancer is not due to a virus. In this case, due to a virus, we were able to do it. We are speaking about a lot of mRNA vaccines that are mainly to amplify the immunoreactivity of the cancer. What's happening? That the cancer has a different cancer cells, they have a different DNA. So why the body cannot recognize the cancer cell as a foreign cell and not able to destroy the cells? In some cases, probably the immune system can do it. In some cases, the immune system can destroy the cells, and your cancer is destroyed before you know about this cancer. In other cases, the cancer cannot be destroyed because at a certain point, the DNA, the cell is different, but not too different than the normal cell. So what's happening that at a certain point, there is an initial destruction of the cell, but at a certain point, the immune system is alert. Look, if you destroy these cells completely, you may destroy other important cells of the body, and the immune system is closed. The cells cannot react anymore. There are new medications now called immunomedications, the so-called checkpoint medication inhibitors, in which the immune system to continue to work, even if the cells are similar. to your normal cells. Side effects, of course, the immune system may compromise some other body cells, but may destroy your cancer. And then there is this new fascinating mRNA in which the DNA is able to enhance the immunity, is able to release more antigens in the cancer cells. And this is the so-called vaccination. So you inject your mRNA, and the mRNA would, at a certain point, attach the cancer cells, release more antigens, and the lymphocytes, the killer lymphocyte, the T killer lymphocytes, able to destroy the cancer cells. So this is another interesting mechanism of possible destruction of the cancer cells. And the checkpoint inhibitors that we are using more and more, this medication in melanoma, in some cancers, and very active.
They say that it's very possible, or it's statistically, the older you are, the more possibilities you have to have cancer. They also say that when you are old, the cancer develops slower. It's a slower development. But there are children with cancers, very young people with cancers. How come it's not only an illness of that you inevitably will end by getting old? Because sometimes, I don't know in which proportions, but there are people who get it, children or adolescent or very young people.
Probably the mechanism is different. When you are old, there is a sort of accumulation of DNA damage. So your cells accumulate more DNA damage that cannot repair, and is the reason why you may develop cancer in general. And your immune system is a little more weak and cannot fight. So this is the mechanism for which older you are and more risk of cancers in general. It doesn't mean
true that it develops slowly in old people, or not?
No, not really. It depends on the cancer. It depends on the biology. Sometimes you have a very good biology and is low, or sometimes you have a very active biology in the cancer cells, and no matter how old you are, the cancer can kill you. From the statistic point of view, the biology of cancers in older people is better from the statistical point of view. But, of course, you can have very aggressive cancer. In young population, children, often the cancer is genetics. What does it mean? That there is a genetic predisposition. There are genes that they don't function very well, and these genes produce proteins able to fix errors in the DNA. So at a certain point, the DNA is damaged, and these proteins are able to restore the DNA. In some situations, there are modification of genes for which these proteins able to restore the DNA, they're not produced. And that's the reason why you have a risk. And then there is another condition that is very, very interesting in this moment. It's very actual, the epigenetics, the so-called epigenetics. What does it mean? That epigenetics is a sort of modification of the production of the genes. What does it mean? You have a gene, the gene works very well, but there are situations in which the gene is shut down or cannot work very well. This situation is due to external factors like diet, like, we don't know, sometimes we think about neurologic depression, something in which we don't know why, but there is a sort of shutting down of genes producing proteins able to modify able to restore the DNA. And the epigenetic is becoming more and more interesting in the cancer field. For instance, we are seeing a lot of women, young women with the breast cancer now. We didn't see in the past. In my clinic, every week I see 3-4 women less than 35. It was very exceptional in the past. And we don't know why, but probably the epigenetic can play a role. What does it mean? They start to drink earlier and earlier. Heavy drink sometimes here in the United States. They are exposed to more hormones. The diet is different. So all these factors may influence the gene production, creating lower level of good proteins able to repair the DNA. This is a theory, of course, but this may be the reason why we are seeing more and more cancers in younger population in general. Colon cancer, extremely rare, but now you can see more and more colon cancers in 25 years old. And before it was exceptional, and they have a perfect genome. They don't have any alteration of the genes from the genetic point of view, but probably the environment, the epigenetic play a role in decreasing the production of good proteins.
The artificial intelligence, which is very much discussed nowadays, yes, no, good, bad. I mean, in your specific discipline, is it a big change? Is it a help for you, or is it a danger?
At a certain point, I remember when the genome was decoded. I remember when the genome was decoded. And I remember articles, again, the decodification of genomes. We would create monsters. We would create a clone of human, clone of bad people, clone of militaries. Fine. The decodification, the genomics was incredibly important. And we are saving more and more life now because we know better about the genomics. And artificial intelligence looked to me the same. It means that we are very scared about the artificial intelligence, but in my opinion, it will be so useful for the future, so useful. We would make less mistakes in treating. We would have a sort of better quality control system. So I think that will be positive. Then, of course, I don't know about the possible bad thing that may happen that didn't happen with the genomics. Probably the genomics is a technology very complex that you will need an incredible skill. And so.
And all these new treatments, Avacta, is this very expensive? Because there is something in medicine that when it's a new thing, it costs a lot of money to do the tests or whatever. Then after a while, it costs less and less until it becomes affordable. Is it the same, or
it's very expensive?
There is no question of cost.
A new treatment, especially for 5 years, when the treatment is patent, is very expensive. So there are medications that may cost $40,000 for one dose for 1 month's treatment. 1 month's treatment. That is crazy. It's incredibly, and it's frustrating for everyone. So you're right. The new technology is extremely expensive at the beginning, and then will become less and less expensive. But the beginning is incredibly expensive. And the big problem in the world is not to create two different medicine. Medicine A for people that can pay, and medicine B for people that cannot pay. So the effort will be to make all the possible new technology available to everyone. This is the fear that the medical field has regarding this new technology that sometimes you cannot afford. The system cannot afford. Some countries cannot afford.
Professor Sacchini, it was very interesting to talk to you. We could talk for hours because you have the opportunity to do this incredible job since many years and to be witnessing every day, every month, something new, and therefore increasing the hope of your mission, right? Thank you for having explained to us readers or podcast listeners so many different aspects, which all together, if I am not wrong, are encouraging.
Yes, we are more and more confident that the cancer can be cured completely. This is what we would like, and everyone would like. In my opinion, we are on the right way.
The only thing that worries maybe us listening to you is that there is such an increase in young people, right? That
Yes.
It's not exactly detected why, but
Yes.
that's the way it is, right?
Yes.
Just a last little question. You know, they say that cancer is one of the worst things to die, but still heart attack is a very diffuse
No, you're perfectly right.
cause of death. The question is, are there also many more heart attacks in young people?
Yes, but if you compare the heart attack versus cancer, there are more people dying for cancer when they are young than heart attack. When we evaluate the diseases, we evaluate the number of years that the disease can take from your life. And of course, heart attack, less years because usually it's old people that can have the heart attack in general, young, of course, but cancer, mainly young people that without the cancer could have been lived for much, much more.
Thank you, Dr. Sacchini. Thank you very much.
Alain Elkann interviews.